evening. This is Planning for Change, a Leader's Vision. My name is Jennifer Livingston, and this is for the School of Nursing and Health Sciences, Capella University. The course is Healthcare Quality and Safety Management under Dr. Beverly. So the gap analysis. A gap analysis was performed on the Progressive Neurology Unit in an attempt to identify any practice gaps inhibiting improvement in our quality and safety outcomes with our stroke program. So a gap analysis is basically a needs assessment that determines the practice gap, what the desired state of the practice gap is, and the cause of the practice gap. So next, let us review this information further to fully understand the importance of closing this practice gap. So the identified practice gap on the Progressive Neurology Unit is that stroke patients are not receiving an aspirin by day 2. Stroke core measure number 5 is antithrombotic therapy by end of hospital day 2. So why is antithrombotic therapy by day 2 important? Well, it can decrease the risk of death or dependency. It can decrease the risk of recurrent stroke in the acute phase. It can decrease the length of stay for the patient in the hospital, decrease stroke readmits, 30-day readmits, and it can increase the reimbursements from the Centers for Medicare and Medicaid, and we'll touch on that further. And it can increase the likelihood of the patient experiencing a full and complete recovery, which is what we hope for. So the desired state. Currently, there's 80% compliance with this stroke core measure number 5 on the unit. Of course, the desired state is 100% compliance with this antithrombotic therapy by day 2. So the result of the desired state will be improved patient outcomes, leading to improved health and well-being in the community, a leaner use of resources, decreased length of stay in the hospital, fewer recurrent strokes in the acute phase, fewer stroke readmits, increased reimbursements from the Centers for Medicaid and Medicare or CMS, and fewer stroke patients requiring long-term care or rehabilitation, more home discharge dispositions, and other immeasurable benefits. When we discuss these numbers, we must realize these are parents, these are grandparents, these are productive members of society who care for their families and add to society as a whole. So having these people out there continuing these things are what's best for society as a whole. So why is there a gap? Well, many reasons. One could be nursing knowledge regarding the adverse effects associated with a patient not receiving an aspirin by day 2. Many nurses may not be aware the benefits of having that antithrombotic therapy in that specific time frame. Or nursing lack of education on stroke core measures, including time frames. For example, with stroke core measure number 5, day 2 is day 2. So if a patient is in the emergency room at 11:59 p.m. on Friday, well, that's day 1. Day 1 is 1 minute. And day 2, the aspirin must be administered by 11:59 p.m. on Saturday. Anything after that is considered out of the window. So there also can be a lack of education and understanding of stroke protocol order sets, including which to use to depending on the type of stroke. So if you're reading an ischemic stroke CT and you see hemorrhagic conversion, or you see petechiae or other things, you may think, which is appropriate? Should it be hemorrhagic? Should it be ischemic? And the parameters and the interventions in these two stroke protocol order sets are very different. So do you then give that aspirin? You're unsure which order set to use. So there's also missing information, including the swallowing ability until tested by speech therapy. You can do a bedside swallow, but any indication of incompetency with the swallow would need to be evaluated by speech therapy, and knowing exactly when the patient arrived or the cooperation level of the patient, mismanaged acuity levels with assignments leading to fragmented care, lack of real-time chart reviews, assuming the nurse before or after you will take care of the requirement. So what affects quality and safety? Well, many things. The existing organizational functions that adversely affect quality and safety are current daily function of the unit is generally running at a chaotic pace due to acuity levels often being mismanaged, assignments being far apart, and a general lack of support due to low staffing levels. And this type of functioning is manageable on a limited basis, but the unit is consistently functioning at these unmanageable levels, and this type of functioning directly affects the ability of staff to provide consistent high-quality care to all and leads to fragmented care. The existing organizational processes that adversely affect quality and safety are unorganized workflows and difficulty in understanding policies and procedures and difficulty differentiating the protocols, and also concerning is a lack of real-time chart reviews and feedback to monitor compliance. And providing feedback helps increase education levels, and the inability to access the stroke core team for unanswered questions or missing information or areas of confusion. They are the experts. The existing organizational behaviors that adversely affect quality and safety outcomes are a lack of staff engagement, a lack of leadership and core stroke team support, and a general lack of educational opportunities and feedback to promote confidence in care being delivered. And how do we improve functions, processes, and behaviors? Well, functioning can be improved by developing an appropriate process to evaluate acuity levels and being more mindful of nurse experience and ability when making assignments. Functioning can be improved with keeping assignments relatively close together when possible, and improved with adequate staffing levels, greater leadership support, especially when those staffing levels are low, and teaching newer nurses prioritization techniques to assist them in streamlining their daily tasks is very important. Often prioritization takes 1 to 2 years to really learn. And processes can be improved by revising policies, procedures, and protocols to remove redundancy, create ease of understanding, and ensure they are current and valid. Processes may be improved with a lean analysis to eliminate unnecessary processes and tasks and to allow for better workflows. They can be aided by real-time chart reviews and feedback to eradicate noncompliance and ensure an environment of continued learning and improvement. And behaviors can be improved by engaging staff in the process of developing policies, procedures, and protocols to promote an environment of inclusion. It also makes staff feel valuable and part of the process and increase their knowledge levels because the staff helped create the same policies, procedures, and protocols. Behaviors can be improved by having more engaged and supportive leadership and direct contact with the stroke core team to answer those unanswered questions and discover missing information and address areas of uncertainty. So existing outcome measures. The existing outcome measures are monitored by the core stroke team via chart reviews. So the chart reviews, they monitor compliance for the standardized 8-stroke core measures. They monitor the length of stay, if the patient is a 30-day readmit, patient compliance with treatment and medications. Will they allow you to give them a rectal aspirin if their swallowing is in question? Stroke and other pertinent education provided to the patient, where they provided education on sensory loss, dysphagia, warning signs of another stroke, how to call 911, very, very important education for the patient. If the recurrent stroke occurrences in the acute phase and morbidity and mortality, and also chart reviews monitor patient discharge dispositions. This is very important. Was the patient discharged home or home with therapies, or did they have to go to a rehab facility or a long-term nursing skilled facility, or did they have to go to a hospice facility or home with hospice? This allows for a clearer understanding of the appropriateness of care provided depending on the severity of the stroke occurrence. So in some cases, the stroke is so severe that antithrombotic therapy is not really going to, help that patient, but still very important that they receive it for whatever measure of improvement they can gain from it. But some of the metrics being measured include the metric of length of stay for stroke patient, and currently that's averaging 4 days, and the number of 30-day readmits is 3. The metric for the number of stroke patients transported via ambulance averages about 15 per month, and the metric of stroke patients experiencing a recurrent stroke averages 3 per month currently, and the metric for patients receiving an aspirin by day 2 is 80%. So remember, we're at that 80%. So if we have, 100 stroke patients, let's say, to make the math easier, and we're at 80%, then we would have 20 having a recurrent stroke. So the metric of patients not receiving an aspirin by day 2, like we said, is 80%, and the metrics of stroke patients arriving within 4.5 hours of onset of symptoms is 50%. And the metric of stroke patients eligible for rehab therapy is 70%. The strengths of the existing outcome measure is that they are relevant and they cover all areas needing reflection. Some of the weaknesses are limited to measurable data and do not reflect all possible outcome considerations, and they can't determine if improvements will change the outcomes. They can only be assumed. So the plan to develop or enhance quality and safety outcomes for specific practice changes to improve adverse quality and safety outcomes for stroke patients and not receiving an aspirin therapy by day 2 is multifaceted, and it involves many fronts. So there must be a decrease in the knowledge gaps. We can accomplish this through real-time feedback from chart reviews. We can do educational modules, change of shift education and bulletin boards, informative emails, online learning and engagement with input for policies, procedures, and protocols, and other various methods to promote education. An important step is addressing areas of uncertainty, missing information, and unanswered questions, reviewing and updating current policies, procedures, and protocols, as we've said, is important, but other possible solutions include a standardized format for neurologists' notes to include all pertinent information necessary for the stroke program's continued success. So that would mean that when you open that neurologist note, there's a place for arrival to the ED, if they received TPA, what time they received TPA, an NIH score, and outlining what they passed or failed in. So this brings a lot of that real-time information there for the nurse to know exactly when things are due and time frames. Another part of the plan is to provide access to the stroke core team by relocating them closer to the unit or on the unit to aid in addressing those areas of uncertainty with stroke core measures, or find that missing information, or they are the expert on stroke and charting it in the computer and taking care of stroke patients. So if there's something missing, they most likely could help you find it, and to answer those unanswered questions regarding care or policies, procedures, and protocols. They are the expert. If there's something that you don't know about a core measure or a protocol, or differentiating a protocol, they should be able to help you with that. A shared vision with leadership, staff, and the stroke core team will be created to ensure consistency, improve standards of care, and self-confidence in care provided. So if everyone is on the same page and same shared vision, then that improves our overall care outcomes. So improving functions, processes, and behaviors, as we've discussed before, will help us become a high performing organization, and that, as we said, is done by developing the appropriate process to evaluate acuity levels, being mindful of nurse experience and ability when making those assignments, and can be improved with keeping assignments relatively close together when possible. Processes can be improved, as we've said, by streamlining those policies and procedures and taking out that redundancy, as policies and procedures are looked at periodically and new things are added. Not always is everything taken away that's extra or double work, so to speak. So going through there and getting out that redundancy is very, very important. And again, real-time chart reviews and feedback, that helps prevent non-compliance, and it creates an environment of continued learning and improvement. Behaviors can be improved by engaging staff in the process of developing the policies, procedures, and protocols, and that way they know them really well. That improves their education as well. And direct contact with the stroke care team for that support, and improve leadership support and engagement. So why do we need a plan? Organization. We need a process, a step-by-step process to tackle the problem and improve our performance and our outcomes. So the plan is based on a lot of assumptions. It's based on the assumption that if we do these things, then everything's going to get better. Our dashboard metrics are going to improve, and patient outcomes will improve, and patient satisfaction scores will improve, and those are very important in today's healthcare. Our leadership, stroke core team, and all staff involved will be more competent and confident in the care they provide, and our financial reimbursements will increase, and our standing in the stroke community will become more prominent by virtue of just compliance with the stroke core measure based on available data. And these are all assumptions that we make based on data that we see of metrics improving in other facilities with higher compliance rates with antithrombotic therapy by day 2. So several steps will have to be taken to achieve this plan. First, it's a collective plan, and we'll need to have stakeholder buy-in to be successful. It's an opportunity for interprofessional collaboration from executives down to floor staff. First, credible data has to be collected to show compliance percentages, and then evidence-based research has to be compiled and presented to justify changes to achieve greater compliance with the stroke core measure. This interprofessional team or committee will have to be formed from all related disciplines to discuss, review, and or change policies, procedures, and protocols, regular meetings with staff for their input and engagement. And then the committee will have to meet to analyze the input and engagement. And then the interprofessional committee will have to agree on any changes, including changes to standardized charting, functions, processes. They'll have to create the shared vision to ensure consistency and continual success. And at all levels of this, communication will be key to have an even playing field. And it'll take on many forms: group text, emails, flyers, meeting minutes, agendas, bulletin boards, online learning modules, verbal communication, and one-on-one feedback during the whole process, the process of planning, the process of implementation. Then there's reviewing and adjusting as necessary. And improvement initiatives quality initiatives are a continuous process. We do an initiative, we improve, and we review, and we see how we can do it better or what else we can improve in. Another gap analysis, consistently pushing our healthcare organization to be better for our community that we serve. So the future vision for the organization, well, the organization will develop and foster a continuous process for improvement and integration, aspiring to be a leader in the arena of advanced stroke care. Improved outcomes will lead to advances in service line capabilities and a general respect in the community and beyond for excellence in the care provided. It could lead to being thrombectomy capable or brain surgery capable or any number of things. The organization will sustain a culture of quality and safety and forward-thinking leadership of educated, engaged, and competent care providers. Nurse leaders, their very important job, will consistently seek to create an engaged and safe work environment where nurses can feel confident in the care they provide and feel supported and empowered to continuously learn and advance their skills. And the opportunities for interprofessional collaboration will continue to exist, highlighting opportunities to further develop leaner processes, improved workflows for continuous growth and development in the stroke program. Now, of course, there's going to be objections. There's going to be objections to the plan, to the processes to achieve the plan, from those resistant to change, those believing that 80% of compliance with this measure is an acceptable level, and those unwilling to engage in the process, and those unwilling to improve their knowledge and skill base. In the process of change, low performers will not be focused on, and then what will result is high performers will be accoladed, and low performers will see that, and they'll improve to seek those accolades, or they'll move on, and either decision is acceptable because it will be what is right for them as an individual. I 100% believe that engaging in this change process will undoubtedly bring improvements to this organization for the benefit of the organization, of the community it serves, staff, and healthcare as a whole. Thank you for letting me present this to you, and I look forward to your feedback. And these are the references. Have a good evening.